directly. We will move on to the next topic, which is the topic of the effects on pain during sexual relations. I am pleased to invite Malkit Spiegel. Malkit is a social worker. She is also a certified sex therapist. She specializes in couples therapy and trauma treatment. She heads therapeutic treatment for the Ministry of Defense. The treatment takes place at the Rodham Center, and Malkit thanks you. Bar is with us regarding psychological issues. Thank you very much. Goodbye, everyone. Wait. We see. Yes. So, good morning, everyone. Thank you very much to Michael and Al, the organizers, Ahava, and the steering committee, for the opportunity to actually participate like this on this important day. As Michael said, my name is Malkit, and I'm handling it. I work with trauma, and will be addressing it for the next 15 minutes. About the psychological dynamics of pain, about relationships, a little bit about the body, that will also be covered later today. I've chosen to focus on a very, very broad topic, of course, understanding the pains of sexual relationships through a model called the 4 clusters, which I'll detail shortly. Wait. So before we talk about the psychological consequences, let's pause for a moment. About pain, it turns out there's an international association for the study of pain. And a few years ago, this association provided a definition. Pain is an experience that is both sensory and emotional. It's unpleasant and related to, or similar to, an experience associated with actual or potential tissue damage. Essentially, this definition begins with the word experience. Doesn't that mean there's a subjective element here? Not every pain feels the same. Even if it's for the same reason, he won't experience it the same way. It's an experience for everyone. It's sensory and physical. It's also emotional. That means there's a combination of factors that influence the pain. And essentially, pain, as was also mentioned earlier, is a biopsychosocial event. This is true even if there is actual damage, and even if there's potential for damage. That means that even the fear of damage can create the sensation of pain. So what exactly is the 4-cluster model? Dr. Yaakov Ezra, encouraged from the Golan Heights, introduced the model. It discusses different types of support for pains in the context of the relationship between body and mind. So, as you can see in the right circle, there are the organic events. Illness. Very clear, very diagnosable, which causes pain. The body affects the mind. Someone who has cancer. It has psychological implications for the relationships they are in, for their self-esteem. If it impacts their ability to function, there's anxiety about what will happen in the future. And essentially, they called it heightened insight. That's why it's all related. There's some overlap between the insight into the physical illness, the organic state, and the psychological consequences. It's very clear. We have other situations that get worse under stress. That is to say, there's some mutual influence of the body on the mind. It's essentially situations. And I'll give the examples shortly. Of course, sexual relations. But these are situations where we have an organic illness. For example, multiple sclerosis. And in stressful situations, the attacks are more severe. There's also insight here regarding the connection. It's not always the case. Patients don't always understand it. And they learn to understand it. The 3rd cluster. That's a syndrome of syndromes of a low threshold. Basically, it's like a magical cycle. I'll detail it shortly, also in the context of sexuality, where the body affects the mind and the mind affects the body. And there's some separation, Ahinoam said earlier. It's very important not to immediately attribute everything to the mind. But sometimes the patient wants to make a separation. Wait, what? Physically. That's not related to the mind. And actually, the understanding is that even what happens in the body is affected by stress. These are situations of stress and pressure. The body is on alert and enters a sort of loop. I'll elaborate more shortly, and there's this condition, the university condition, which is essentially mirror syndrome, as you can see in the illustration below. The mind creates and influences the body, essentially a subconscious conflict. For example, something Dr. Ezra always gives, he was a neurologist in the military. The recruits want to be combat soldiers. But internally, they have a conflict stemming from the very act of enlisting, fear of dying, or other reasons. And they develop headaches that they have no physical source. It's just an unresolved conflict. So, after I removed the illustrations from the model, I asked the AI to arrange it in a way that would show us this more visually. Basically, the more physical dominance there is, especially in very clear organic situations, we'll also see a significant increase in the level of insight. It's easy to really explain it to the person asking. Now I'm speaking from an emotional perspective. That means people with organic conditions will also come to us. Soon, as I mentioned, I'll discuss this in the context of sexual relations. That makes it easier to explain. She comes to us, a woman who had surgery in the postpartum, or any other surgical procedure that causes her pain. It will be possible to understand why she's developing psychological difficulties. And as we move towards psychological dominance, it will be difficult in unconscious conflicts. There will be a greater need to try and uncover this. Also, the level of insight regarding the connection will be lower. Women will also find it difficult to accept and hear that it's purely emotional. I reiterate and emphasize it's very important. We, as sex therapists, not as emotional therapists, to make diagnoses independently and to work in collaboration with others, healers. With physical therapists, truly, they are the ones who can provide the diagnosis. They know how to treat it. So, what does that look like in terms of pain in relationships? So, if we go with the first cluster where the physical factor is the primary cause, then we're talking about clear physiological reasons. Something like the emotional distress that comes with recovering from surgery can be very significant. We'll need to see how to help the patient cope with the new situation that has arisen for her after a car accident, or after an injury. I'm talking about women, that's true, but also men. Even when there's a physical cause, a clear cause of pain during sexual relations. The second one is that the patient has a diagnosis, for example, endometriosis. During times of stress, there's an increase in the pain. We'll need to help her discover the triggers together and how we can reduce them to lessen the pain. We'll start now with the third cluster and then also the fourth. And essentially, in the third cluster, we have additional trauma related to low threshold syndrome or ongoing stress. Michael said earlier, things that are close or far away, those can actually be events happening right now. We certainly aren't lacking in emergency routines in our reality, difficulty with a partner, situations of stress and pressure. And essentially, the system is on high alert. This can also be due to past trauma, and therefore the body is on high alert. I worked for many years in the Gaza envelope. The example I would give to my patients, which is a little painful today, is this. I'm not sharing it, but it's like a security fence activating. Every bird that lands and doesn't break through it essentially creates a constant overreaction. Tensed. The body enters a state of stress, releasing substances that don't encourage moisture and the ability to relax and experience pleasure. The system is in a state of overstimulation. It's as if it mistakenly enters this state. Now it's a magical cycle. It doesn't always just get distorted. There's a memory of the pain. But because the memory you see is actually a circuit, it doesn't matter where I enter it, because the distress will increase the stress, which will increase the somatic response and worsen it. Symptoms of the flare-up include swelling. They also include urgency with urination. Additionally, there is pain in the vagina. Only when a conversation is also important for the diagnosis. I'm talking about that for a moment in a zoom out. I'm talking about the whole process that happens within the pain. And then the distress intensifies. It rises. The despair that Dr. Ohad also spoke about is present. He said I wouldn't be able to get rid of it. And people are looking for medical explanations in situations where insight is lacking. There's no understanding that the body is actually entering a certain state. It's experiencing stress and feeding itself. We see this not only in pain during sexual relations, which is the topic we're discussing today. It's sexual pain. But it can also be increased back pain. It can also be increased abdominal pain. Essentially, the source isn't just organic. Or is it exacerbated by a mental state? And essentially, there's some sort of magical cycle that's very difficult to separate. What caused what? The relationship, the partnership, that too will surface later. During the lecture later. In the fourth cluster, we have conversion disorder. Basically, the pain. It's the tip of the iceberg of everything that's happening to the patient within her mind. Now this situation is frustrating because often we hear doctors say it's all in her head, go to a psychologist. And they don't make the diagnosis. Even when the pain really does have emotional consequences, this diagnosis, whether the source is physical or emotional, and its consequences is important. But it's also confusing, because this cycle really creates confusion. But I'm talking about situations where the mind is truly within. The psychological consequences, they are the cause of the pain in the body itself. It speaks what the mind isn't able to say. I've worked many years with survivors of sexual assault, with the diagnosed and undiagnosed illnesses. Their experiences are really intense. It's truly a lack of ability to express themselves, and generally to share. What they've been through manifests itself in physical symptoms. Some of them develop into illnesses. Or yes, some develop illnesses that can be diagnosed, and they would be in the second or third cluster. And sometimes there are just pains that can't be explained. All the tests are negative, and there's nothing to point to. And essentially, we understand that there are hidden conflicts here, and we need to enter a deeper emotional process. This doesn't mean we won't send him, her. We'll be in touch with a medical professional to reduce something. The physical symptoms. We won't just stay with the emotional treatment. Because in the end, there's also the physical suffering. The thing is, treatment focused only on the physical aspect can lead to frustration. That is to say, pain relievers. Pains that aren't given space. They won't work on the psychological effects either. So, I've written down a few examples of hidden conflicts we have, like power struggles and control issues in a relationship. Sometimes the pain is enabling. And they'll expand on that later. It allows someone to sit on the switch of control within the relationship system. If in the relationship system that's visible, just the tip of the iceberg is above water. The partners have more control. So the hurting partner can enter a control position. He states when to have intercourse if at all. They control the relations. Everything needs to go according to them. His tone. I'm not saying this judgmentally or critically, of course, there's no need for that. To have sex and suffer, but sometimes it expresses some kind of need. A desire for control and avoidance. Rejection. We talked about this here. Michael brought up the disgust. She spoke of moral revulsion. I had a patient who experienced this on the day she did. That she began to feel disgusted by her husband's behavior. She discovered less moral and less valuable aspects of him. These aspects bothered her greatly. They began to surface. The pains. When, in fact, previously it had been secondary pain. So it was easier for her to understand that something was happening here. More unconscious conflicts. A clash between the desire for intimacy and feelings of guilt, shame, prohibition. That is to say, on the surface the woman or the man, I'm sure, wants her, but beneath the surface there are all sorts of psychological messages. Whether they are cultural, religious, or personal, that the son or the woman, a woman or man, developed for themselves from things they read and learned them. Even a small example, the word itself, penetration, shows this. Biblical, we use the word bea. When something comes to me, I can choose whether to let it in or not to let it in. A guest who comes knocks on the door. The word chidira today, certainly after July 10th, evokes connotations of intrusion, of invasiveness, of pain. Just the word itself can cause me to say, I really, really want it. But there's something within me that isn't willing or guilty. Shame, a patient once told me. How can I have a relationship when God is angry with me about this experience? It's forbidden. It's not right. Room. She wants it to hurt. No physical things were found. We are working on resolving this internal conflict. The additional conflict could be a deep fear of intimacy. Also here. I worked with a couple. Actually, the pain was with the man. It started for him on the day the relationship became more committed. Pain. It's not a one-to-one correlation, of course, but essentially everything was connected. Okay, before and on that day, it felt like a deeper commitment to something more intimate and emotional. He was accustomed to maintaining relationships without coming from an emotional place. That's when the pain started. It brought up all sorts of things from his childhood, and from other relationships as well. Sometimes anxiety about pregnancy, so she may say, yes, I want to of course, but we can't because I'm in pain, and passes everything. The process is difficult and I want to go to the gynecologist. They made diagnoses. They performed tests. She even went to physical therapy for the pelvic floor. And everything hurts. All the trainers, and it hurts me. How am I supposed to manage? Just a couple of minutes. 0 minutes 1 second. Or anxiety about pregnancy. I keep going in the opposite direction. That's it, so we're just 2 slides away now. Common personality traits of women experiencing pain, sexual relations. I'll go out on a limb and say, of course there's a spectrum. Doesn't mean everyone is like that. Michael mentioned catastrophizing, perfectionism, and a lack of psychological flexibility. All of these things can both predict pain and intensify it. The pain. We talked about negative body image. These, and essentially it will affect how we respond. When we know how to differentiate the pain, if it's coming from the organic cluster, we will address it differently. It involves functional considerations or from the conversion cluster. Above all, it's important to pay attention to the impact of the pain on the couple's system. And I'm here to introduce Ruthie, who will be joining us shortly. And essentially she'll talk about how treatment within the couple's system can also affect the pain. So thank you very much. To everyone. Thank you. Malkit. Are there any questions? I remind you all, you can write them. Questions and answers will be available at the end of the lectures, and now, I'm pleased to invite Ruth Salmon. She is a bibliotherapist, instructor, and therapist. She also trains therapists using the arts in the Ministry of Education. And she is a parent instructor, a graduate of training from the Rodham Center for Sexual, Couples, and Family Therapy. She is a licensed sex therapist specializing in the treatment of sexual trauma. Ruth will speak about how girls and boys cope. Thank you, Ruth. Hello everyone. I'm very happy to be here. Proud to be here. In the next 15 minutes, I will try to expand and deepen the look at pain, like what really began, and to examine and see what happens to pain when it enters a sexual partnership. She also investigated how the pain affects the partner then. Let's begin. Pain is ultimately a private experience for each person. Every one of us experiences pain. Every one of us has something in their body. It's possible to see pain as a closed experience of a person with themselves. They don't need to communicate it to anyone, or say anything about it to anyone. As we get older, we have more volumes. Every one of us, I'm sure, has something in their body. Something that can remain a completely private experience. By the way, genital pain in the genitals, can also remain and exist in a personal space. I'll set a timer now, and it can remain in a personal space, and it's not needed to communicate it to anyone. I can tell you about one of my patients. She's a swimmer, an Olympic swimmer, really professional. She has pain with inserting a tampon. And, of course, it affects her every time she swims and competes when she has her period. She's completely in charge of it. She doesn't need to talk about it with anyone. It has nothing to do with anyone else. She decides how to manage it. When to manage it or whether to let it go. Whether to not give up is a question. We see that pain is beginning to change. It's happening at a very, very significant turning point. It's called intimacy. That's a transition point before. And to believe, of course, that the word relationships exists. Another person entering my space. And the pain begins to change. It begins to change because it is from a personal event. It's becoming a dyadic event, and from a private space it's becoming a shared space. The pain is coming to light. It's visible. It's present. It requires attention. It demands a response. I won't speak about pain that isn't brought to light in this session. It doesn't require a response either. It's part of the foundation of. Often there's trauma that belongs to another session. I will, however, speak about the thing that truly holds pain. And it's shared between spouses within their marital space. Pain exists between the two spouses. It becomes a component within the marital dynamic. There is no way to see it, ignore it, or pretend it isn't there. Before I project the slide in its entirety, I really want you to look at the drawing that I managed to design with so much effort. We all played jacks when we were little. Most of us at least played jacks. We know that 2 fit inside a jack set. It's not like 3 fit inside a jack set. In my opinion, that's the very best example of a system. Because we're inside, we move away. We move closer, we stop, we stretch. Every movement we make affects the other person. There's no way to avoid having an impact. We're inside, so we're inside together. Let's think about what happens when a couple is within this situation. And he's playing with himself. And then suddenly another player enters this system. With not such pleasant feet. His name is pain. And you can't bring players into this system without them playing. It's simple. Impossible. And it's also impossible to talk about pain from a systemic perspective without mentioning Bowen. You could say he's the architect of systemic treatment. Even though he spoke about marriage as a shared emotional system. Emotional system. And he taught us that when pain, a player named sexual pain, enters our system, anxiety actually begins to rise. Systemic anxiety, not just of the person experiencing the pain, yes, or of their partner. It's anxiety of the system. The tension spreads, it begins within the system. Triangles start to emerge. For anyone familiar with family therapy, essentially, we have another partner for our relationship, another person who has something to say. And not just something to say, but often becomes a focal point that fosters intimacy, creates distance, organizes patterns of behavior. They are very dominant in this system. And even I will use a slightly less pleasant word. And I'll say they're even a little manipulative. Yes, Malkit mentioned that earlier. In her slide about the hidden, repressed pain within the sea of the subconscious. We have questions related to our self-esteem. And yes, a woman might want to ask if you still want me? Do you still love me even though I'm hurting? I can't give you what you want. A man can ask what's going on. Are you interested in me? Do you like me? Even though every time I get closer to you, you pull away and shut down. These are very deep questions indeed. This is the liquid gold of emotions. Yes, and very much so. People want to say them but don't always have the ability. And what are we able to do? We are able to talk about pain. To say, I'm hurting, or I'm not hurting. Yes, today no, today yes, we will do it, we won't do it. We don't really talk about the things that are important to us. Incidentally, like in every triangle, I'm adding a line here that speaks about distinction. As I mentioned a toe, but I won't talk about it now. I'll leave that for the lecture following this one. However, I will say in the dictionary that the smaller it is, the greater the distinction between partners, the more opportunity we have to communicate about these challenges in the relationship through pain. But I won't say any more about it. Wow, it's 10 o'clock. We're all hungry. And I thought it would be appropriate to use the analogy of a layer cake to describe the ecology of relationships. It's all really about that. The first layer, which is usually uniform across all cakes, is some kind of standard pastry. Let's look at it that way. There's pain, and we won't dwell on where it came from right now. It's in the foundation. Layers begin to form on top, like on a good cake, strawberry cream cake, hazelnut whipped cream, whatever it may be. I'm really hungry, and it's possible. It's possible to see how one settles into this pain. Layers settle into this pain. Personal history, if there's trauma, if she is aroused, if agitated. How does one get in? Attachment patterns in relation to pain? Issues of rejection, of abandonment, of persecution. What communication skills do we have here? How can we express and communicate this to one another? What perceptions do we have about sexuality? What perceptions do we have about intimacy? What are we building on this foundation of pain? As the connection between partners becomes deeper, the impact of the pain becomes more complex and more varied. That means I have more to lose. That means I might resort to more manipulations. That means I'm more exposed. That means I'll be more vulnerable. I really mean every couple. And it's important for me to say that. He bakes his pain in his own oven. Or he makes something very, very special for each and every one. And I think that we should open a huge display case of all the pain cakes. Seems like there isn't one. It looks just like its companion. Just as the faces of people are different, so are their pain cakes. They are influenced by everything about them. Their identity, their transgression, their disposition. Very, very unique to each pair. Let's take a look at couples' reactions. They manifest in the relationship when pain appears. Let's look at the drawing just a little. And let's really try to think about what's happening. What do we know that leads to anxiety turning into pain? So we know these responses of the F's. The fight, the flight. We see both the fight and the flight in this drawing. But really, just as the cake is different, yes, we remember the previous transparent cake. And it's special, so too are the reactions to pain different. We see that there's really on one side avoidance. Come on, let's go, we have such a nice friend. A good relationship. Let's not deal with anything related to sexuality. We continue against through defense. It will be okay, updating can adopt it. Can't, what can be like that? Let's not, maybe it's not a good idea. And there is. We have the other side. Maybe of the fight, let's go again and again. And we'll try one partner too. It affects their partner. Pressures them as well. Also, some kind of self and personal pressure. What can I, as the one experiencing the pain, do? We really went from nothing to the absolute worst. And I think the response that saddens me the most is a response of disconnection and dismissal. It's also connected to trauma related to sexual relations. When they don't feel their body, I don't feel the soul. I don't feel the partner. This is a response. It's incredibly difficult, incredibly sad, and it exists, as some result of pain, adapted to each person's emotional and mental framework. And the systemic framework of this couple. I'm not talking about that. We started from the beginning. I also want to say a few words about the research in recent years. From TIN. The last 15 years that they have been found. Very much like Natalie Rosen. He talked about systems. So there's definitely some kind of very clear transition from the private medical terms of pain and sexuality. This transition leads to broader terms like couple problem. Dyadic system really conditions and decides that pain in sexual relations is a couple's experience. Therefore, the new thing is that it's also being researched as a couple's issue. She says it's not some experience that we know is a couple's experience. Rather, Natalie Rosen distributes questionnaires to both the man and the woman in heterosexual relationships. They express their feelings. They are being researched as a couple in sex therapy, training sessions and lectures. We'll find the words of who this hesitation is from. Whose vulvodynia is it? That is to say, it's clear that it's coming from one partner. Natalie Rosen and similar names using code names are discussing the intensity of the pain. Really, just think the intensity of the pain changes. It's influenced by the partner's reactions, how mutual this really is, and so too is the level of anxiety. Naturally, we can understand and agree that if there's pressure, and if there's tension, and if there's romance, and if there's violence, then there will certainly be a worsening of the pain, and a worsening of the anxiety. I think I learned from Rosen that overnurturing too is not cool. Hearing that it's not terrible and maybe you can't. That also has a correlation with worsening reports of pain in women. That's something we can see. Encouraging responses promote adaptation. And open communication correlates with a decrease in pain. In anxiety, a few words about on. Morbidity. Or, we see there is pain in the system. He enters and activates the anxiety, and we can begin to look for these sexual dysfunctions. For example, if there is pain and anxiety, we can develop vulvodynia or vaginismus, for example. And then there is some rejection of all sexual relations, and a negative sexual experience, and reactivity begins. Dr. Ahinoam spoke about this initially. She talked about this vicious cycle. She talked about it. And what I want to say here in the context of this is that one sexual function, for example the woman's vaginal function and vaginismus, can ultimately provoke male sexual dysfunction. For example, is often going together with performance anxiety or with rapid ejaculation to eliminate it, and to avoid all the hassle, that unpleasant business. And it's truly a very difficult and very sad cycle. By the way, according to research, women with this sexual function have many more men with sexual function. It's interesting to see. It might suggest something a little optimistic. That if we really have research showing how it's best to talk and communicate with our partners, in order to reduce pain, they have actually developed therapeutic models. These models address couple integration for mutual regulation. We teach therapists how to communicate. We teach therapists how to talk. We teach therapists how to be one with each other. Because we know there are communication patterns that encourage a reduction in pain. These patterns also encourage a reduction in anxiety. So why not do them? We're almost finished. And here I'll move the picture of myself so I can see what's written here. I'll begin. I'll tell you in just a few seconds about what we saw here in my lecture. So we talked about how pain moves from a private space to a couple's space. How it enters the system and affects it systemically. We discussed a specific pain cake for each couple. It's created based on their foundation, violation, disposition, and how they function. We talked about reactions that shift from freezing to overactivity. We talked about that. We discussed how a partner's reactions physically affect the intensity of the pain. This impacts all mobility between sexual functions, and it impacts our ability in treatment to develop helpful communication patterns that reduce pain and anxiety. And as Michael told you, I also use bibliotherapist. I incorporate a lot of writing. It's suitable for some of the treatments. And I want to end my presentation with a poem by Yehuda Amichai. Look, just as time isn't inside the clocks, love isn't inside bodies. Bodies only show the love. So let's remember that concrete pain is foundational. And we must deal with this whole layered cake. And certainly it is very meaningful to us. Thank you very much. Thank you. Ruth, thank you very much. The last speaker for our session is Alicia Azar. Alicia is a clinical social worker, a guide, and a couples, family, and sex therapist. He is a co-director of the Rodham Center. He is the head of the Rodham program for training couples, family, and sex therapists. And Alicia will speak about intimacy with pain in the background. Thank you. Thank you. Yes, good. Goodbye. I'm really excited about this. That the discussion is systemic, I didn't understand that initially. It's through Ruth's things, she's a professor Lev S02, that I understood. Ahinoam also said that about the circle at first. A circle is essentially a systemic perspective. I think, and I will continue to view things from a systemic perspective. I believe it's a point of view that can be very significant for us. Something because what is the suffering in this pain? That's clear to all of us. What is unpleasant about the pain? No, we don't need to teach anyone something about that. It's about how pain enters a system. And the truth is, you said, Ruth, that researchers study pain as a shared experience or... Right, that's wonderful. It's very significant. But I think it's not always necessarily so at all. We experience symptoms, not necessarily pain. It's an expression of something specific. You gave the example of a cake, and I'll give the cake too. This example is one we use often. We use it when we're talking about what? About systems, and I want us to try and look at partnership not as a system, like exit services, but rather at intimacy as a system. I'm focusing, of course, on romantic intimacy. And there's a cake here. When you look at it, it's not clear what we're going to do with it. We're going to experience it. We're not going to eat it, as you can see. It's made up of many different things. Within the intimacy of every intimate interaction, we think intimacy is an experience. We think intimacy is a moment between partners. But intimacy isn't an experience or a moment. Intimacy is a system. When we are within an intimate experience, we are actually within a system composed of each of us being here. You know, intimacy can also exist within a group, but we are talking about couple intimacy. So, the two of us are here with our bodies, with the physicality of our bodies for better or for worse. With its sensuality, with its pain, with our fears. Our memories of everything that came before, and our expectations of each other. And all of these things go together. And the truth is that because all of these things go together. So I think this cake isn't the right expression for the type of this system. Why is this a system? It's just a jumble. And it's not just because I was in the secret forest. I ate tons of salad there. And I discovered that you can gain weight from salad too. That's not the reason I brought salad. Rather, it's because the salad represents a system in a more accurate and meaningful way. Because what happens in a salad? There are so many ingredients. And the system is something new. But this new thing is a new taste or a new texture. It's a new sensation. It's a new feeling. But it doesn't mask the ingredients. And if one ingredient gives too strong a flavor, I can try to do something with it. For example, onion. Most people don't like to eat raw onion. It's not a good experience. It's an experience for most people, but not everyone. It's an unappetizing experience. It's too sharp when it goes into a salad. Then it's a different experience. It has a different meaning. It adds something to the salad. What happens if I put in too much salt? What happens if I put in too much onion? Well, often you can balance it with lemon. Maybe it will balance the salt. You can do some kind of adjustments within the system. It says the system is constantly in operation and under influence of all of its components, but we have it and it has its own mechanisms. Through them we are trying to balance. So if we're talking about pain now, then a good analogy for pain within an intimate experience is an onion. It's not something that is pleasant in and of itself, but we can ask ourselves what happens when it enters into the couple's experience. Into the intimate experience, we get into bed. And there's also the possibility of pain. I will focus on sexual pain. Not because all pain of any kind from any source is necessarily the same. So what are we going to do with the pain? If we have a way to deal with its presence in a way that allows us to enjoy the experience. Just think for a moment about the sentence, pain inevitably harms intimacy. Is that sentence true? Or is it not true? Yes, it's not true because imagine a couple experiencing pain. And yet, they still manage to feel good. That means they have an ability that is even more significant than other people's. To feel pleasantness. It means the presence of pain enhances the intimate experience. The intimate experience becomes a more meaningful one than it would have been without pain. So, ultimately, it's a point of view. We can look at a field that has both flowers and thorns, and focus on the flowers. We can focus on the thorns. Or I know what I'm saying now might also be a little risky. That people will be put off by what I said. It's like it obscures the intensity of the pain, so I completely understand it's not that. It's a very significant thing that colors other things, in very, very strong colors. And yet we can still ask ourselves within the relationship experience what can be done. And in sex therapy many times that's what we focus on. For example, if there's pain during sexual relations, can you tell yourself, okay then without sexual relations that include penetration, perhaps other things that don't involve pain. We often see couples in the clinic who experience pain. Because of the pain they don't do anything at all. And then the question arises, why? Why don't they do anything? Apparently, there's no reason, right? Just learn. And we also see that often people are sent to learn, or we give them exercises, or some such thing that says, come and expand what's enjoyable between you. It doesn't always work. Why doesn't it always work? Is it because there's a cycle of stagnation? Okay, because that's what it is. That's what happens within an experience. An intimate experience that involves some unpleasant experience, for the sake of clarity. The experience of pain is an unpleasant experience. So there's some point in every system. We don't know what the starting point is. It's always a cycle. So I have some kind of memory. A memory of a previous intimate experience. That existed. That involved pain. The memory isn't clear. It's the physical pain, maybe the shame, maybe everything it was. It led to a war, and it's leading to a war now. It leads to a war within the person's soul, with the pain. It leads to a war between spouses. Almost everything that leads to a war ultimately leads us to reduction. Because I will again be here in the future. This intimate experience is not a one-time thing. It's not a flirting encounter. I know. So I will restrain myself in order not to relive what I know to be unpleasant, from memory. And also so that it won't happen again. To avoid bringing in experiences that might hurt me. That is to say, the cycle of restraint means I will avoid even things that might have a chance of being pleasant. Because I don't want to build up expectations. It's better if this doesn't happen. Because even if it works out now, who's to say it will work out tomorrow, right? So it's best for us to limit our sexual experiences as much as possible. Just to what's safe, but when there is an opportunity. When there's pain, it often means what's safe remains terribly, 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 terribly limited. And what's left is loneliness. The loneliness of a person with themselves, and the loneliness brings him back. To us, back to the experience of pain. And to the experience of unpleasant memories. So now if you pay attention, you'll see that within this cycle we don't have the word pain. And the reason we don't have the word pain is because the pain is present at every stage. Pain accompanies us all the time. It is pain that allows us to enter into the intimate experience. Not necessarily with physical pain, but also physical pain. And also the memory of physical pain from previous days. And with the emotional consequences, as both Ruth and I mentioned, we know to what extent it has repercussions. All of this is factored in. All of this guides us. And we're just busy telling it. And we're not available for anything else. And ask yourself, as we said earlier, that what we can offer is to add even more things that don't cause pain. So apparently, or rather not apparently, the most important thing a person needs to know about themselves is to say, wait. Did I bring something? No, but it doesn't quite fit. I said maybe we'll try to do something and it's not working. It hurts. If there's anyone here or anyone who has been at a point where they felt this sentence needed to be said, please try. But they can't say it. What's stopping this sentence from being said? Take a moment, let me have it. From yourselves. Why is it sometimes hard for us to make the move of acknowledging the pain as it is? In a terribly, terribly simple way. And I think the answer is, it's often related to the fact that we care so much about the other person. We care a great deal about others, and we also care about how they react to us. We care about how the other person feels. It's not just because how they feel is significant to me. It's also because how the other person feels reflects back to me. How I feel or who I am or what my significance is. Or others. That's a saying, to talk about distinction without saying the word. In other words, often it's precisely a very positive stance that it seems to come from a wonderful, moving, caring place, a very intimate connection. Sometimes that very stance is what makes the intimacy irrelevant. What makes the intimacy irrelevant? That is to say, if I'm constantly apologizing for who I am, and I feel like I'm disappointing you, and I also feel like I'm disappointing myself, what kind of person am I? What kind of person am I that brings pain into this relationship, into this experience? Why is there this failure all the time? So there's this feeling of guilt in this cycle. This mental stance is the engine of the stuckness cycle we talked about earlier. Something needs to move those wheels. And that something is actually this stance of wanting things to be good. Ask yourself what the stance is. So, what is it to become a sociomat? I don't care, of course not. But it is a stance that says, I want to be present here with everything I can bring. I want to be present with all of who I am. I can bring, and not just be busy wanting things to be good here. Because if I'm going to bring everything I can bring, it could very well be a disappointing experience. For example, it's possible we won't have some kind of sexual experience that will be really good. And maybe at some point I'll say that sentence I said earlier, I need to stop. It's not pleasant for me, it was nice. I hoped it would be nice, but it's not pleasant for me. It's possible it will be really unpleasant for you. You'll tell yourself, so what was the point of doing it? It would have been better not to get involved in this at all. But it was worth it. Why was it worth it? Because I don't want to give up on what's truly enjoyable. And if they've already given the image of a salad, then we can't give up on the oil. We know that today olive oil is considered a staple, something very, very healthy and significant. And it's a little. And it takes me a little to the image of looking at pain. This happens in the context of chronic illnesses. So, in chronic illnesses we can look for the root cause of the problem. Look for the reason as if not. I'm looking at the reason. We know today that aspects of nutrition or aspects of lifestyle have a very, very significant impact. They are very, very closely linked to this story of chronic illnesses. Why? Because how the system works is often, or perhaps almost always, more significant than how a specific symptom behaves. It's not just linked. It's a great analogy for pain problems too, because oil is often also the solution to a pain problem, even issues in the body in the context of sexuality. But not only that, oil has this property of softening. When we introduce it, it has this property of connecting components. Sometimes a salad can look lifeless. We add oil to create vibrancy. This happens through the connection of everything. So this position of softening, this position of the ability to say, yes, please come in. Perhaps yes, there are people present. Although it could be difficult. Even though it might hurt us. Even though it's really unpleasant not to do this. Absolutely not doing this by force. From a place of pain. But to do it. From a place of compassion. Self-compassion. Not compassion for the other person, who for the moment deserves it. How long can he hold back? In a place that accepts me. Even with all the pain and challenges. But also with everything that he is. It's not pain with so many things that are beyond the pain, because as we know, and Ruth also said earlier, pain is always part of a system. And pain is also, sometimes it's not who we are. And if we manage to reach mentally from this position into the experience, then we can utilize the systemic characteristics of intimacy to allow intimacy to be not just able to be. Even though there is pain, but sometimes at the end of this whole process that we described, perhaps the intimate experience will be immeasurably more moving and more meaningful, especially in the presence of pain. Thank you. Thank you for listening. Thank you very much. Alicia. Wow, what a session. Thanks. Amazing, each and every one. Ruth the Queen is invited to open camera. There are a few comments and some questions from the audience. So Shall we begin? Hassan asks. Sometimes feelings of guilt and shame arise among one or two partners. These feelings develop throughout the experience of pain. The question is, how are these emotions typically handled? We have a few minutes and a few more questions, so this topic can be discussed for 11 more hours. Who wants to answer? I think Alicia mentioned this toward the end of his presentation. I don't know when the question was asked, but just the recognition itself. The recognition and dwelling in the feelings. Those of guilt, of shame, as I called them in my lecture, that's liquid gold. Something so soft, so important for connection. And it's there when there's intimacy. Yes, when there is. A committed relationship requires intimacy, so it happens in the most natural way. Feelings of guilt and shame also arise when we have gaps or difficulties, and the precious opportunity to acknowledge them and stay with them together. Not to reinforce them, not to ignore them, not to postpone them, not to distance yourself from them out of compassion. I really loved the image of the oil, Alicia. Compassion for myself, compassion for my partner. I think they are the key to positive communication. What else can I offer moving forward? It's a mental stance that isn't something to adopt. Don't look at it solely in terms of treatment related to sexuality, but in life generally. And the stance is, what are feelings of guilt? Often in therapy we say we aren't. Or in a relationship, you're blaming me right now. This is considered something bad that one person does to another. But guilt, is it? It's the ability to look at what I did and ask what I can do to improve. So guilt can be amazing and wonderful. It can also be terribly bad and dangerous. When is it bad and dangerous? When I look at what I do and say to myself, I'm not worthy. This is terrible what I'm doing. And it's not a position that takes me anywhere toward growth. It's a position that only leads to self-destruction. Many teenagers do this sometimes. They're experiencing themselves, who they are, and it's hard for them because of what they're doing. So if we can learn throughout our lives not to run from guilt in places where we truly need to feel guilty, that would be good. And to know when there's no reason to feel guilty, because failing at something doesn't mean I'm not worthy. Quite the opposite, I am human, I am worthy, because all people fail and so do I. I think this practice in the course of life could be very, very significant in these areas of sexuality and pain, where our personality is stretched to its limit, where we are tested in our most powerful moments. It's not a place to start practicing. It's a place to realize what we've already learned about ourselves. I'd also like to add that this applies to other emotions within a relationship as well. That's what creates intimacy. Often, people think they'll find a solution to a problem. You're in a place of intimacy where there's no emotional pain. It simply is. The ability to share feelings, even the painful ones. That's what creates intimacy. That's what creates the sense of oneness, the separation between me and you. And also the ability to connect with and move the other person. And to express myself. So I'm saying you shouldn't be afraid of difficult emotions. They're there. Who go through this can remember a moment of such clarity when they said something difficult. But precisely then, they felt a very strong connection with the person in front of them. Because they brought themselves in the most open and honest way. And it's often around difficult feelings that a sense of connection will be. It's really hard to touch on that. But they really feel the connection precisely in those places. I wish for all of us, for everyone, that we'll be in a partnership that allows for that vulnerability. And not to get hurt. But wait, but it's not necessarily that. I'm raising you all up a bit. You might feel self-conscious about it. Something you can work on. But what I'm trying to say is that it's not always possible. Sounds wonderful though. And it's the ideal that we can be in that position you're in. To accept myself. It's amazing. But I'm saying anyone in the audience who feels they aren't there. Yes, there are many times when you need to know and also have luck and also work to reach that desired point. And what is it? But it's precisely a quiet point that isn't found and you return and go, that's it. Not necessarily a quiet point. It's a very painful and very turbulent point. Yes, but it's still a privilege to reach it. Yes, to be in pain, to embrace it with compassion. It's not a place you take a bus to get there. There is opposition. Trains, that's a simpler question. It should be simpler than what to do when your partner isn't cooperating with the problem itself. And doesn't believe in treatment methods. Like when you want to talk about your doctorate. That's a question, but I'll tell you, I understand you. If you want basic conditions, how can one person influence a system alone? Is that yours? It's really a question that occupies a lot in therapy. And it's not necessarily related to pain. That's exactly what Michael said. What happens when the other person isn't around? So what we often see in couples therapy, in all the variations of relationship challenges, is that we put a lot of pressure on the other person, in an attempt to move them to where I want them to go. They don't want to come to therapy, so what am I supposed to do? I'll pressure them as much as possible to get them into therapy. The problem is that in most cases this pressure doesn't work. That's the problem. That is to say, we don't have and won't have here any magic solution. Such a solution doesn't explain how to convince the other person to come to therapy. Sometimes there isn't one. No divorce is simple. It will convince. But when a person comes from a place of threat, the question is whether they are coming from a position of change. Does it invite them to a position of change? Not necessarily. Therefore, we truly have no practical choice. This choice is the ability to deal with things on our own. But we do have that ability, regardless of whether you care, and whether it interests you. I don't care what you do, and I need to do the best I can with what I have, and to invite you to participate or come or not. And if you don't come, I don't know what will happen in the end. Maybe in the end we won't be able to handle it. This is what I can do or what I can do. It stems from my experience as a couples therapist. Often this approach engages the other person. Very often, the pressure to change the other person stops. Suddenly, the other person is willing to hear about the possibility that he can change, because he cares. I think the starting point is whether the change will come only if he initiates it. Am I placing all that happens within us on him? Or do I know how to identify my own part within this relationship? And what isn't, as you say? Not just to change, but also to acknowledge what is beyond my control. That is my position. The approach, how I address him, saying come to therapy whether I want you to be with me and for us to be together. Or I think everything will depend on whether he comes to therapy. I have an idea for a study. I don't know if anyone has ever done it before. Michael, can you say perhaps, regarding pelvic floor physiotherapy and the connection between the degree of intentions? At the level of fulfillment, I have a feeling that when someone comes from a place where they really want to please their partner, they want them to get what they've grown tired of giving. Coming from that kind of position, I have a feeling that it will hurt the ability of the treatment to be meaningful. I don't think the mental attitude of coming because it is meaningful for me, that I want for myself is meaningful to me. That is not an egotistical position. That is the most connected position. That is the most intimate and couple-like position there can be. And therefore, coming to therapy and the desire to say, okay, I have pain, I'm coming with what I can. Or I'm coming with what I can. It's not just that there's no choice about how you can influence him. It's also genuinely significant. That's it. That's the position that has a greater chance of making the relationship more meaningful and intimate. It's simply right for me and I want it. Just to mention the rubber band image. You can't play with rubber band alone. Once we're in this game, I'll move forward. Band 103600:59:18, 610, 00:59:22, 720. It definitely affects both of us. That means the responsibility is also. Even if only one partner makes their move, it does. There's no way to ignore this change. One way or another, but there's no option within the system. Nevertheless, I will say that sometimes we encounter women who say, I've had so many treatments. I go to physical therapy. I've had individual sexual therapy. And he's not with me then. It's frustration because, beyond everything that's been said that I agree with, the frustration is deep when a woman deals with the pain that is the pain of the system. And she essentially needs to do all the work by herself. So you're right. There's no, let's call it a weakness issue or something like that. That means I think we need to approach it from a position of strength. It's the power that I have in my hands, it's what I can do. It's not from a place of vulnerability. Quite the opposite. But you're right that sometimes we do take it too far. There are sometimes relationships that need to end. It happens because the other person isn't involved. It's just like there's nothing to be done about it. That's true. Life is complicated. You're right. And the goal of change isn't for them to change. That's not the goal. I think the point of choice here is also very critical. I don't know if we'll have enough time, but I want to structure the questions this way. And if not, then I'll ask you to answer in writing in a different chat. Questions following up on what was said before. How should they come after the delay in those feelings? Is it right to be compassionate and remain in those feelings? How do you move forward from there? Perhaps, and the question is Ruth. Could a supportive response, for example, facilitate adaptation? Would it help with the reduction or disappearance of pain and anxiety? So, choose one because we have 3 minutes before the next session. And there are more questions here. I will answer the question about low threshold syndrome in writing. I will also answer in writing questions that encourage adaptation. It's a shame these are questions. I am. So, does that give me freedom to make a cup of coffee? I like the question about what to do after, being involved in this. I don't even know if anyone really knows what to do after this stage. It's a wondrous stage. Nobody knows what happens there, because it's like a new landscape opening up. My teacher said that if I jump into the pool, then I know how to be on the jumping board. I also know how to be in the water, but this whole space between, I have no idea. Some kind of thing, I don't know what it is. And I don't know what will open up for me. That's the feeling. And truly, if we're going to a place and planning how it will be afterward, we're not on the right track. We need to let go in a way that we don't know what will come of it. Could turn out to be something much better. It's possible we'll need to part ways in the end. Yes, but we must be true to ourselves. And know that we no longer want what we had. We're ready to stay with this pain and whatever unfolds. We will do what needs to be done. A list of what has opened up. I'll tell you. As the faces that are different, so things that will open up will be different. I'll say that there's someone here writing that all the questions will be answered as more answers become available. The truth is, yes, it will be like this all day. We have 1 minute, so we'll add another small question. What about Alicia? He said regarding physical therapy and pelvic floor exercises, he's really right. How do we change the way we think about ourselves? That there's a reflection of all the questions, it's so legitimate. And I'll say about that, I just don't have it. I don't have an answer. I think the question is the thing. And if the question is strong enough, then something like that growth might happen. That's it. Not really. I can't be like this just as a lecturer anymore. I need something to connect with to happen for me. It has to come from within, from a personal confrontation. There are no shortcuts to this. Thank you very much. We will now hand the stage over to the next session.